You guys do like intros. Okay. Good morning, everybody. We're going to go ahead and get started. It's March 31st, 2022. Like I was going to forget something. Sorry, I'm trying to hide video. Eating toast. Okay.
I was gonna do it like here.
Or side by side.
Yeah, I could flip through the.
I can
slides.
move the computer over. Would you rather have it here?
Maybe I still like.
There we go.
Do you guys have any audio? Like
No,
that you need a speaker or anything?
No, we're not that fancy.
Okay.
All right, good morning, everybody.
Here, but these guys are gonna be here, so do it this way.
Yeah, over there, yeah.
Here, we'll do this.
We have a rookie.
Ah. Is that good? That way you're not.
Perfect.
Yeah, it's us.
All right, we'll get started.
Oh, it's okay.
It's okay. More donuts for us.
7 people on Zoom.
Oh, perfect.
Go ahead and sign in.
All right, so I'll start with introductions. I'm Jace Burton, CA1 in anesthesia.
I'm Chica Losu, also CA1 anesthesia.
All right, and today's topic is going to be on atelectasis. Just a brief outline of what we'll be going over today. We'll start off with the case that should be familiar to all of you here in the PACU. And then we'll go over some etiologies of hypoxia, go over the definition of atelectasis, some things that why atelectasis occurs and how it presents for patients being brought to the recovery area. And most importantly, how we manage it in the preoperative period, intraoperative period, and for you guys in the postoperative period. So I'll start with the case. We have a 65-year-old female. She is obese. She's brought to the PACU after having a lap chole under general anesthetic. She's arousable to voice, still a little sleepy, as most patients are, being wheeled out of the operating room, and she's not in any acute distress. We hook her up to monitors, and her vital signs are as follows. She's got an SpO2 of 98% on 2 liters nasal cannula, heart rate of 87. She's normotensive at 112/75, breathing 16 breaths per minute, and she's afebrile. Shortly after admission to the PACU, her nurse weans her from the supplemental O2, and then shortly after, the monitor begins to alarm for an SpO2 of 87%. Her respiratory rate has increased to 22 breaths per minute, and her other vital signs remain mainly unchanged. So what do we think is causing this patient's decreased oxygen saturation? So with an oxygen saturation of 87%, that's classified as mild hypoxia, which is an SpO2 of 80 to 100. And now, as clinicians, we start to think, why is this occurring? There's many things that could be causing this. One of the main reasons in the PACU would be hypoventilation. And that can be caused from either like pharmacologic etiology. You know, did the patient get a lot of narcotics intraoperatively? Is there residual neuromuscular blockade? Another cause of hypoventilation would be if the patient is splinting their breaths because of pain caused by deep breathing. And that's common in like abdominal surgeries, mostly like open abdominal surgeries, not as much in laparoscopic. And then other thoracic surgeries, anything you think that would like really cause pain with movement of the thoracic cage. Another cause of the hypoxia could be a VQ mismatch. Atelectasis is one of those causes of a VQ mismatch, and we'll go over that more in a bit. More concerning would be things along the lines of like pulmonary embolism, either gas. You know, this patient did get insufflation with a laparoscopic cholecystectomy, so it's possible that they nicked a vein or something that would cause gas in the venous arterial system. And then there's clot pulmonary embolus, which I'm sure we're all familiar with. Other causes of hypoxia could be a diffusion defect. Does this patient have, in patients that have known congestive heart failure, did they receive a lot of fluids in the operating room, and maybe that exacerbated some pulmonary edema? And then we, of course, frequently see patients with intrinsic lung disease that includes COPD, emphysema, and then there's other more rare lung diseases that can cause diffusion defects, making it more difficult for the oxygen to cross those alveolar membranes. We also have intracardiac shunts. These are usually known, especially in our case with this adult patient. It would probably already be known if they had a heart defect, a hole between their left and right ventricle or left and right atrium. So, we're probably putting that lower on our differential. And then there's also low FiO2, which is rarely seen here at sea level, but for completeness, we included it. Could possibly seen, higher elevations, Colorado, Aspen, Denver. So we're not really thinking low FiO2 for our patient. Let's say we look back at the centricity script for our patient. We see that she really didn't get much narcotic, just maybe 100 mics of fentanyl for induction, but not much more else. And it looks like she received adequate reversal for neuromuscular blockade. So that leaves us, one of the most common causes of hypoxia in the PACU is atelectasis. And do you want to go over this one?
Yeah, so basically atelectasis is just loss of lung volume due to the collapse of the lung tissue. This leads to interpulmonary shunt. And so just a fun fact, atelectasis is a combination of two Greek words meaning imperfect expansion. And so we kind of have a little diagram here, just a close-up of the alveoli. And there you can see it's lost due to the inadequate expansion. And then this is Theo, Kelsey's dog. So, and then just some information about atelectasis. So it's actually the most common cause of hypoventilation in PACU. Actually, 90% of people who get general anesthesia will have atelectasis. And so 15 to 25% of lung tissue becomes atelectatic. And it can occur within 5 minutes of induction of anesthesia in the dependent regions of the lung. And so if the patient was supine, you would see it in the posterior regions, the atelectasis. And so we can look at patient risk factors as well as surgery risk factors, people who are more likely to get atelectasis. And so some patient risk factors include COPD, asthma, people who will have decreased compliance of their lungs, people who are obese and pregnant, and so they do have like decreased
excursion of their diaphragm, for those full deep breaths that really open up the lungs. If you're obese or pregnant, you have increased intra-abdominal content that's preventing the diaphragm from expanding your lungs maximally.
The elderly, as you get older, you're going to have decreased compliance of your lungs, less elasticity. Surgical risk factors include like cardiac surgery and being on bypass. So when you're on bypass, you're not being ventilated, and so those lungs are collapsed for quite some time. Abdominal surgery, positioning, talked about how supine positioning can also, and prone positioning could affect those dependent regions of the lung. Using a high FiO2 intra-op. I think we're going to talk about it in a little bit, but basically how a lot of that oxygen is going to be diffused from the alveoli leading to collapse. How long the surgery is, how long they're going to be in that positioning, how long they're going to be receiving that high FiO2. And then interscalene and supraclavicular blocks. And so you can have diaphragmatic paralysis, and so you're not going to be having that that breathing, and so that can also lead to decreased expansion of the lungs.
All right, so that's my dog Penny. I don't think we introduced her.
Oh, yeah.
She's my 1-year-old dachshund. She's a cutie pie. So 3 mechanisms that cause atelectasis. We've briefly touched on it already. One of them being gas resorption. So normally when we're breathing air, like, just ambient atmospheric air, it's not 100% oxygen, as we know. It's, got nitrogen, carbon dioxide. A lot of these gases don't readily cross the alveolar membrane, and so they stay within the alveolus, keeping that alveolus open. When patients are on 100% FiO2, however, oxygen does readily cross the alveolar membrane. So, there's less gas in the alveolus that's propping it open. Like it's missing the nitrogen, a lot of the carbon dioxide that would, prevent atelectasis. So high FiO2 is a known cause of atelectasis. General anesthesia is also known to impair the function of surfactant. So when we're sitting here like we are now, you'll notice intermittently you'll have a deeper breath. That's all of our wakeful spontaneous breathing is not the same tidal volume. We occasionally yawn. These things are mechanisms that keep our lungs fully inflated and prevent atelectasis. However, during general anesthesia, we usually, set a tidal volume and a rate, and they're not getting those intermittent deep breaths. So that also affects the surfactant ability to keep our lungs open. And then it's known that anesthetic vapors themselves decrease the function of this surfactant, increasing the probability of atelectasis. And then, as we've talked about already with pregnant patients, obese patients, and then, if it's abdominal surgery and causing compression, it's the compressive forces that decrease the functional residual capacity and lead to atelectasis. So in the PACU, obviously if 90% of your patients have atelectasis, you've seen this many times before. The clinical presentation can range on a spectrum from, symptomatic dyspnea, breathing faster. If you listen to them with your stethoscope, you may hear crackles in those dependent lung regions that are atelectatic. So you might hear some crackles. You might see the diminished chest expansion that's causing the atelectasis, or in many cases, you won't really see any symptoms. You'll just see the numbers on the pulse ox being low. Diagnosis generally is a diagnosis of exclusion. We're not getting chest x-rays or CT scans on all of our patients in the PACU. But I found this picture, which I thought was a good demonstration of that loss of open lung volume after a general anesthetic. So as we see here, the lungs, air is marked as black on a CT scan. So in this image, we can see that the lungs are fully filling out the thoracic cavity here. And then after induction, as we know, during induction, we give a paralytic agent and the patient goes apneic, they're not breathing. So the lung volume contracts. And, depending on how difficult their airway is, it can take a couple of minutes to secure the airway and start delivering breath to the patient. So after induction of anesthesia and securing the airway, we can see here that these dependent regions of the lung regions that, are most affected by the gravity, we see like a decreased volume of expanded alveoli. So instead of being filled with air and showing up black on the CT scan, this section of the lung is actually appearing more like a soft tissue because there's not as much air in the alveoli. And we see that here in the posterior regions of the bilateral lungs. And there's more Theo.
So there are ways or strategies that we can use in different areas of like preoperatively, intraoperatively, and in the PACU to help minimize atelectasis. And so preoperatively, just having like preoperative patient education physiotherapy for patients who are more prone to having allostasis and smoking cessation. We've been all shown to help minimize allostasis, as well as high-risk patients and patients who are going to have heart surgery, undergo CABG. Having intensive inspiratory muscle training is encouraged. Intraoperatively, I know we mentioned a little bit earlier about things that can cause allostasis, and so things like making sure that adequate tidal volume. They say now evidence shows that having like 6 to 10 mils per kilo is the best range in terms of having for tidal volumes. Minimizing apnea time, especially in patients who are more prone to people who have like COPD and asthma, people who are a little bit older, and they want to have a more skilled provider, maybe not a medical student in today, just to make sure that you're minimizing that time of desaturation. PEEP helps, just kind of improves gas exchange and respiratory mechanics. Recruitment maneuvers are very useful in this, just making sure that we're recruiting those compressed alveoli. Lower doses of opioids and neuromuscular blockade. And so kind of just minimizing the amount of respiratory depression that we may have, that may help keep those alveoli open. And then also utilizing regional anesthesia when appropriate. I know earlier we talked about having the super quad, the shoulder blocks, those can kind of counteracting that, but just kind of minimizing the amount of general anesthesia when it is appropriate is best. And then I think everyone we've seen allostasis out here in the PACU, so everyone's really familiar with how to treat it. But when it has been diagnosed, or when we do recognize it out here, oxygen to maintain adequate oxygenation out here in the PACU, promote wakefulness and deep breaths. We have our incentive spirometry out here, and then CPAP with RT. These are all things that we all are familiar with out here. And then there's plenty. Yeah. And that's it.
Any questions?
Thank you.
Did everybody get a donut? A second donut?
More donuts left over too.
Lots of donuts.
Yeah. Yeah.
Thank you. What's in the shower?
They didn't tell me.
It might be a regular long john. Well, there is something in there. I see the access port.
Yeah.
Oh, yeah, maybe stop recording.
Yeah. So, oh, it sucked.
Good work, guys.
Thank you.
Thank you.